Understanding of anal anatomy and classification of fistula and ano. Dr. Samrat Zankar bring greetings from Kaizen Gastrocare, Symbiosis University Hospital Research Center, Pune. This presentation has been done in 19th Amosicon. I am thankful for organizing committee, Dr. Kalpesh sir, for giving me opportunity. What we have learned till now, I think we need to erase it. This is the biggest hindrance in fistula treatment. We need to understand modern anatomy and concept which has been devised and proven and seen on cadaver by Dr. Rajna Sukal. That will solve us treatment of the fistula. Let's focus on the anogenital muscle, anogenital fascia and anogenital spaces. This is the part which is important when we are dealing with any kind of fistula. Muscles has been conceptualized by Dr. Rajna Sukal sir as three-level concept. There are three level anogenital striated muscle: upper level, middle level and lower level. A muscle which extend from coccyx to pubis and which has all component: ischiococcygis, pubococcygis, ileococcygis and deep part and puborectalis. But on cadaver what he has seen is one single unit, and what is importance we need to know is at any cost the levator component we should not damage. If levator component damaged, not repaired, the incontinence is inevitable. Second component is the superficial external sphincter, second level which has a superficial external sphincter which connect to the coccyx by anococcygeal ligament, separated anteriorly from perineum membrane by superficial transverse perineal muscle. Third level is subcutaneous external sphincter, which is correspond to bulbocavernous, which can be very well demonstrated on fresh cadaveric dissection, has been done by Dr. Rajna Sukal sir, and this image belongs to Dr. Arun Rajna Sukal sir, and this is levator anus, superficial external sphincter and subcutaneous on MRI 3-level concept. Going to anogenital fascia, there are only 3 fascia which are important we need to keep in our mind. In between the two sphincter, intersphincteric, the fascia which start at the junction of levator and superficial external sphincter and goes obliquely to the obturator fascia, that is ischio-anal fossa fascia, and going transversely at the junction of superficial and subcutaneous. This can be also seen on cadaver and ischio-anal fossa fascia, transversalis septum fascia, and these are the infralevator space, ischio-anal space and perianal space. Anogenital spaces. Anogenital spaces, these are medial spaces, intersphincteric, supralevator space. These has to be drained inside the anal canal at the level of intersphincteric groove. Lateral spaces, these are perianal, ischio-anal, infralevator. These has to be drained from the skin incision at the area of maximum fluctuation or tip or highest area. Deep spaces, these are the two deep spaces, deep postanal, deep perineum spaces. We never leave undrained these places, otherwise the infection recurrence as an abscess or fistula going to be. Medial spaces, this is the internal sphincter, external sphincter. In between, below the dentate is low intersphincteric, above the dentate is high intersphincteric, and extending high intersphincteric space above the levator is supralevator space. What we call this space as ischiorectal fossa, but what should we call? If something lateral to anal, we are calling ischiorectal. If it is actually lateral to anus, it become a confusion. So Dr. Rajna Sukal mentioned this as a misnomer, and he suggests name as lateral to the external sphincter space as ischioanal fossa. If we are having this ischioanal fossa, there is ischioanal fossa fascia which is there in that space, which is starting at the juncture between the levator and superficial external sphincter that goes obliquely, and which divide ischioanal fossa fascia lateral into a two infralevator and ischioanal as a two spaces. Deep space, this is perineum, which anterior urogenital, posteriorly posterior anal triangle. Urogenital triangle at the level of perineal membrane become a superficial perineal space and deep. So we can see in the cadaver there is a transverse perineum, superficial external superficial perineum space. The perineum membrane which has opened, and down we can see the deep perineum. This is a male patient with anterior high transsphincteric fistula going through the deep perineum. Posternal space, we can appreciate that levator, anococcygeal ligament, superficial external sphincter, internal sphincter, and intersphincteric plane. This is the area where we can see the deep has been shown on cadaver. We can see that there is a anococcygeal ligament below the anococcygeal ligament at the center, and outside the external sphincter we can see deep postanal. We can see this video where the deep postanal space approached from the internal opening and drained and completely opened up. Purpose of classifying any fistula mainly to categorize various presentation of disease for better understanding, stratification of the disease according to severity or complexity, to guide the clinician in treatment strategy and classification. What we follow as a surgeon classification, which is one of the most simple, easy and surgical classification based on the physical examination and intraoperative. This has been done in pre-MRI era, mixed type of fistula in every class, like the low intersphincteric and high intersphincteric are in one group. The low transsphincteric, high transsphincteric treatment option varies from sphincter cutting to sphincter preserving are in one group, and data is skewed. The most are in type 1, type 2 and few are in type 3, type 4. The extrasphincteric, suprasphincteric type are usually iatrogenic, has been documented, which has given a place of type 4. What radiologists follow, this is St. James. This is MRI based classification. It is most widely used by all the radiologists, but this is also more or less like Park classification. It doesn't help much in surgical planning. We can see grade 1, grade 2, that is intersphincteric abscess and fistula are Park type 1. Grade 3, grade 4, that is transsphincteric abscess and fistula are as good as Park type 2. Grade 5 is as good as Park type 3 and type 4 clubbed in one. Standard practice task force, this is has given very simplified fistula classification, simple fistula, where the fistulotomy going to have risk of incontinence high, those are complex, or low, those are simple fistula. The purpose is very simple, make the better surgical decision so that we can do the fistulotomy which is having the best result, and if there is a risk of incontinence is high, keep it as a complex and prefer going for the sphincter preserving surgery, where we can expect risk of incontinence is low but recurrence is high. Drawback of this system, 32% of complex fistula were amenable for fistulotomy. There is overestimation of complexity, not useful for differentiating different types or patterns of complexity and determining. This is wonderful classification devised by Garg and really great. Almost 800 plus patient has been applied and validated. This is the best which one available at present. which is none other than Pankaj Garg. But this classification also has few drawback. This is mainly rely on MRI, not readily available in every institute. Many sub-classification it's challenge to remember as there are grade 5 with subgrades, so it become bit of difficult to remember. And complex cases suprasphincteric extrasphincteric are into a single category even though they have unique pattern. But at the same time, when Garg has been published data about these are iatrogenic, so iatrogenic fistula also considered in this class. Rajna patterns. The pathogenesis of anogenital sepsis, primary anogenital sepsis, always travel a path of least resistance except prior surgical intervention or non-cryptoglandular disease. So the infection we know usually start at the dentate line, crosses the internal sphincter, reach up to the intersphincteric space, then it get trapped. It cannot cross the internal sphincter because of the inflammation. Internal sphincter goes on spasm. It has to go a path of least resistance. Those path can be down in between the sphincter, that is a low intersphincteric, going up in between the sphincter, high intersphincteric, crossing the bundles of subcutaneous external sphincter or in between the subcutaneous and superficial. These are low transsphincteric, reaching up to perineal space or ischial space, going in between the levator and superficial external sphincter, reaching into the infralevator channel. This is the high transsphincteric fistula. The fistula which travel or sepsis which travel in between the sphincter come out is low intersphincteric type. When it crosses in between the bundles of subcutaneous external sphincter or between the superficial and subcutaneous external sphincter, this is low transsphincteric. The high transsphincteric, when it goes anteriorly into the deep perineum space, it becomes anterior high transsphincteric. Posteriorly, it goes to deep postanal space, which become the posterior high transsphincteric. When sepsis travel between the sphincter and goes up above the levator, it is a high intersphincteric. Low intersphincteric pattern, it can be abscess or fistula. For the sphincter cutting procedure, which is the better option, and definitely when there is a low transsphincteric, let it be abscess or treatment is very simple, go for the sphincter cutting procedure, except if there is anterior fistula in female, recurrent fistula, a post radiation or IBD Crohn's disease. Anterior high transsphincteric, where we have to go for sphincter preserving procedure, which is the posterior high transsphincteric fistula, we have to go for sphincter preserving procedure. The posterior high trans can be three patterns. One is maximum 80-85%, which follow horseshoe fistula, where the sepsis travel from internal opening into the deep postanal space and goes either side of the infralevator ischial space. This is a horseshoe type. It can be a bilateral horseshoe, unilateral horseshoe, or the abscess may limit up to the deep postanal space. Sometimes from deep postanal space goes below the anococcygeal ligament and present as good as pilonidal abscess, and sometimes which doesn't goes to the deep postanal space and directly open either on the side of ischio anal or infralevator. So most commonly is horseshoe type. Pilonidal sinus presentation is less, 5 to 10%, and without going into the deep postanal space is also bit of less. The procedure here is sphincter preserving procedure is high intersphincteric, which travel above in the intersphincteric space from the dentate line, either as a high intersphincteric or present as a supralevator. Treatment is very simple, intraanal fistulotomy, either going from the dentate or going from the intersphincteric groove, divide the internal sphincter. It can be extended up to the level of levator. one of the most complicated pattern is posterior high transsphincteric and high intersphincteric type, which has both patterns, and this need a sphincter preserving procedure, which can be intraanal fistulotomy and ligation of the fistulous tract over the external sphincter and debriding the abscess component or infective pathogen. Fistula pattern and operative option: low intersphincteric type 1 sphincter cutting, low transsphincteric type 2 sphincter cutting, anterior high transsphincteric sphincter preserving, posterior high transsphincteric sphincter preserving, high intersphincteric sphincter cutting, that is intraanal fistulotomy, combined pattern type 6 sphincter preserving. Whenever there is a sphincter cutting, the best is fistulotomy, fistulectomy, whatever you prefer. Fistulectomy is much better option. When there is a sphincter preserving, this can be ranging from lift, waft, fistula plug to sphincter cutting, that is fistulotomy, immediate sphincter repair. Anything can be, whatever best in surgeon hand can be applied. Thank you.